So autologous transplant is just high-dose chemotherapy, which is so high dose that it kills off a lot of cancer cells and also puts the bone marrow in aplasia or hypoplasia. And the idea is to put the stem cells from the same person collected before doing that to the patient and getting rid of the disease and rescuing their bone marrow. Patient has to be chemosensitive to this high dose of chemotherapy before doing all this. Again, as I said, we use it mostly for multiple myeloma and non-Hodgkin lymphoma. Dr. Hashmi did an excellent presentation on why multiple myeloma autologous transplant is still the winner despite having so many new options. For autologous transplant, a few things to consider. One, the patient has to be sensitive to chemotherapy. So we give them chemotherapy to control the disease. And that also tells us if doing autologous transplant will be a good idea. The conditioning is something called myeloablative, very high dose chemotherapy, usually involving high dose alkylating agents. We do a combination of chemotherapy with what we call BEAM in Hodgkin or non-Hodgkin lymphoma and high-dose melphalan in multiple myeloma. Some data behind why we use that. So in patients who had relapsed large B-cell lymphoma, this CORAL trial was done back in 1990s, early 2000s, and it showed that about 50% of patients can be cured by doing a autologous stem cell transplant after high-dose chemo. And for multiple myeloma, determination study is a very recent study which compared transplant to doing a combination of 3 drugs alone, and it showed that the progression-free survival, which is the time from transplant to the disease progression, improves with transplant. It did not improve the overall survival because we have so many good options to treat multiple myeloma patients, and the follow-up, despite being 7 years, is still shorter for that.